Good evening, good afternoon, good night to everybody in this big and beautiful world. Welcome, welcome, and thanks for taking the invitation for being with us in this webinar, SEMCAM webinar. So, in behalf of SEMCAM, which in Spanish means Consorcio para el Estudio de la Nefropatía Mesoamericana in Centroamérica y Mexico, or in English is the Consortium for Study the CKDu in Central America and Mexico. I give you a very warm welcome. So welcome everybody. We prepare an amazing talk of one of the most important topics we think is involved in this disease. It's for me a privilege to co-chair this session with Suchi Anand. Suchi Anand is a very well-recognized nephrologist from the Department of Nephrology at Stanford University in the Bay Area in the Northern California. And introduce myself, Vicente Sanchez Polo. I am the head of the nephrology department here in Guatemala at the Instituto Guatemalteco de Seguridad Social. So first, I give the word and the mic to Suchi. I just want to tell you some suggestions. First of all, please stay the mics off. Everybody, the mics and the cameras in off is for better, the technology situation is better if we can mute our mics and put out our cameras. Second, the comments and questions are we take at the end of the talk. So you can write in the chat, you can put in the chat. So Suchi and myself are going to take that questions and the comments. And at the end, we are planified to have a amazing, really richness time for the comments and the questions. So let me introduce you again, Suchi. Suchi, thanks for being with us, and you are going to present our speaker from today.
Yes, thank you so much, Vicente. And yeah, it is my extreme pleasure to introduce Julia Wijkström. She is a dual doctor, now an MD as well as a PhD at one of the most renowned research institutes in the world at Karolinska Institute. She's a nephrologist there, and she, as some of you may already know her name and recognize it well, because she has been at the forefront of evaluating the pathology of Mesoamerican and CKDu in kidney biopsies, and was the lead author of one of the earliest studies that looked at CKDu in Mesoamerica in 2013. And she's been continually active in this area, trying to advance our knowledge using pathological techniques. And some of you may have heard a version of her talk at ASN, which was very well received, and we're really looking forward to having Julia talk to us today as well. Thanks, Julia.
Hi. Thank you so much for inviting me to have this speech, and thank you for all you attending this seminar despite of these special COVID times. So maybe some of you have heard parts of my speech earlier, but I have also some new slides. So I'm going to talk about the histopathology of CKDu in endemic regions. So this is the outline of my speech. I will talk mostly about Mesoamerican nephropathy, but also some biopsy studies from Sri Lanka and India. So short background, in 2010, when I was getting involved in research regarding Mesoamerican nephropathy, kidney morphology and clinical characteristics were largely unknown, and only a few kidney biopsies had been evaluated. And I think it was at ASN Kidney Week where Professor Linder from Karolinska University Hospital and Dr. Ricardo Leiva from Hospital Rosales met and initiated this collaboration to look at kidney biopsies in the region. So why do we perform kidney biopsies? Well, it is a routine investigation in investigating patients with chronic kidney disease and in some cases also acute kidney disease. It can provide a specific diagnosis in the most cases, and it gives information about the type of injury, the severity and activity. And it is important for individual treatment and follow-up. It is performed by looking at the biopsies with light microscopy, immunofluorescence, and electron microscopy. And this is performed by experienced renal pathologists. So what is the relevance for CKDu research? Well, it is of course to distinguish from other known kidney diseases, but also to compare between different CKDu epidemics. To describe type of injury, is it glomerular damage, is it tubular, interstitial, and so on. And also to grade the activity. There are of course limitations. To take biopsies is an invasive procedure with risk of complications like bleeding or hematuria. And you need access to renal units with experience of biopsy procedure. And it cannot be performed in end-stage renal disease. And also it could be some, the renal biopsy preparations and stainings can differ from different labs. So we have conducted 2 collaborative studies in Central America, the first one in 2012 in El Salvador, and the second one in Nicaragua in 2014 in cooperation with Marvin Gonzalez. And we use similar inclusion and exclusion criteria and analyzed the biopsies at Karolinska Institute, both the biopsies and blood and urine samples. And this resulted into publications in American Journal of Kidney Diseases. The study design was similar in both studies with inclusion criteria, a CKD of unknown cause from endemic regions with an eGFR of 30 to 60. Exclusion criteria, diabetes, uncontrolled hypertension, and nephrotic range proteinuria. We collected kidney biopsies, blood and urine samples, and questionnaires. So these are the results from these 2 studies, from El Salvador here and Nicaragua here. And as you see that in the first study, we had 8 patients, and in the second study, 19 patients. So these are small studies. You see that in the second study, we have somewhat younger and patients with somewhat better renal function. But in both studies, the patients have been working for many years with agriculture work, in most cases, sugarcane work. So looking in the blood test of these patients, this was not really a common knowledge back then, but we actually saw that a lot of patients had these low levels of electrolytes, low potassium, sodium, and magnesium. And in the urine, most patients had no or low range of albuminuria, but many patients had increased levels of these markers of tubular damage. And they also had high urine or large urine volumes. Looking at the potassium excretion, we found that there were signs of renal wasting of potassium in those patients that were hypokalemic. So now we come to the kidney biopsy and the morphology. And first I would describe the changes in the glomeruli. And we were kind of surprised to find this kind of extensive glomerular damage, since the clinical picture is of a tubulointerstitial disease. So we found this high percentage of glomerular sclerosis. We found 2 cases in both groups that had segmental sclerosis, and in the remaining glomeruli that were not sclerosed, all of them were enlarged in different degrees. And also all but 1 patient had these signs of chronic glomerular ischemia, and I will show that later what I mean by that. So here are some slides from the patients, and here you see this is a sclerosed glomeruli, doesn't function anymore. And here you see a glomerulus with a segmental sclerosis. And this is what I mean by chronic glomerular ischemia. This is a thickening of Bowman's capsule, also called periglomerular fibrosis. And you can also see a wrinkling here of the capillaries in the glomerulus. And the other slide shows glomerular hypertrophy that was found in all patients. Looking at the tubular interstitium in the biopsies, we also saw chronic changes, mostly of mild to moderate degree, with tubular atrophy, interstitial fibrosis, and interstitial inflammation, but mostly of mild to moderate degree. So here are some slides of the tubular interstitial changes. Here you see these areas with tubular atrophy, and here on the other slide you see streaks of interstitial fibrosis. Looking at the vessels in the kidney is of course important, and here we found mostly normal vessels or mild changes with mild intimal thickening or mild smooth muscle hyperplasia. So here are some slides from the patients. You see this is a normal large artery, and here another slide with the normal artery and normal arteriole. So the changes we see in the glomerulus with the ischemic changes, that we can see if we have hypertension induced nephropathy, but we don't see then you should also see a lot of changes to the vessels, which we don't do. So looking with the electron microscopy, we saw some unspecific changes in the podocytes. You see here some vacuoles, some intracellular fat droplets, and also actually in some areas foot process effacement, even though the patients didn't have much albuminuria. So to summarize, what we found in these two studies was that we found a similar pattern in all patients in El Salvador and Nicaragua, a combination of chronic tubular interstitial and glomerular changes. Vessels were mostly normal or only mild changes, and immunofluorescence was negative. So then this biopsy study was published in 2014 by Lopez Marin and collaborators, and they used similar inclusion and exclusion criteria as in our study. They included 46 patients and also some female patients, and they evaluated the biopsies with light microscopy and immunofluorescence. And here are some slides from their publication, and here you see an enlarged glomerulus with the segmental sclerosis. But they also had reported more vascular changes, but here you also see this thickening of Bowman's capsule. And here is more slides, and here you see some streaks of fibrosis and also an enlarged glomerulus. So this is their data in a table, and they concluded that this was a chronic tubular interstitial nephropathy. They use a different grading of the morphology compared to our studies, but if you scrutinize it, you see that it's kind of similar findings. They present somewhat more interstitial fibrosis, but otherwise mostly mild tubular atrophy, mild inflammation, and the glomerular hypertrophy was common. So, and then in 2018, this really interesting and great paper was published by Rebecca Fisher and colleagues. This group had previously described acute Mesoamerican nephropathy, that it was sugarcane workers with acute kidney injury and an inflammatory illness. So they wanted to look at these patients and biopsy them. So they included patients from a hospital in a large sugarcane estate with a acute kidney injury in combination with leukocyturia leukocytosis or neutrophilia, and exclusion criteria were hypertension, diabetes, and so on, and also positive urine cultures. 11 patients were included, and they found the biopsy findings to be tubular interstitial nephritis with a varying degree of inflammation. They also saw neutrophils in the tubular lumen. This is something that you normally see in pular nephritis, but remember these patients had all negative urine cultures. The authors also reported that glomeruli and vessels were mostly normal. And so they also suggest that this may be the primary lesion in Mesoamerican nephropathy. So now I'm going to leave Central America and go to Sri Lanka. As you know, there's been reports of high prevalence of CKDu in rural areas and many similarities with Mesoamerican nephropathy. There are actually a number of biopsy studies that has been published from Sri Lanka, and this was one of the first one in 2011 by Attaralia and colleagues. They studied 3 populations in Sri Lanka, and they screened them for dipstick proteinuria, and only participants with proteinuria were included. And they found the prevalence of CKD in this north central region for 5%, and that is not really high, but remarkable was that 87% of these CKD cases had CKD of unknown cause, and 26 of these patients underwent kidney biopsy. And the authors write here that the light microscopy findings were indicative of tubular interstitial disease, and immunofluorescence was negative. They also present some pictures in this publication, and they describe here the renal fibrosis, but also the thickening of the Bowman's capsule. This is another study from Sri Lanka by Nana Yakara of 57 patients, and patients with severe hypertension and diabetes were excluded. Both males and females, CKD stage 1 to 4. And they present detailed morphology, but no biochemical data in this publication. And if we look here at their results in the biopsies, we can see a lot of similarities with Mesoamerican nephropathy. You see here some cases with focal segmental sclerosis, glomerular enlargement was common, a high percentage of glomerular sclerosis, mild to moderate tubular interstitial changes, but they had somewhat more vascular changes, but half of the patients had hypertension and hypertensive treatment. We performed a collaborative study, our group at Karolinska, together with Dr. Jaya Samana and colleagues at Polonnaruwa General Hospital in India, in Sri Lanka, using similar inclusion and exclusion criteria and study design as our previous studies in Central America. And in this study, we included 11 males, and most of them have been working for many years with agriculture work, mostly paddy rice farming. But it was a big difference in the workload and the heat exposure in this group compared to the group in Central America. Mean eGFR was 40, and we also found low levels of electrolytes in this cohort as well. In urine, we found similar findings as in Central America, and signs of renal wasting of potassium and magnesium in the patients with hypokalemia and hypomagnesemia. So, but these biopsies were a bit more difficult to study because the individual biopsy findings varied more than it had done in our previous studies in Central America. So 6 patients had findings similar to what we have seen in Central America with this chronic glomerular and tubular interstitial damage. But 5 patients had other morphological diagnosis. 2 patients had a more classical chronic tubular interstitial nephritis, 2 patients with signs of pular nephritis, and 1 patient with nephrosclerosis. Okay, so to summarize, it was more heterogeneous in Sri Lanka in this small study compared to our previous studies in Central America. Some biopsies looked like what we saw in Mesoamerican nephropathy, but we saw more inflammation, more vascular changes, and these signs of glomerular ischemia was not as common. But similar findings in blood and urine. But this was only 11 patients, so we need to study this in larger studies. So only short about India and CKDu in India. There's been some reports now of CKDu in rural areas in India, mostly from the Andhra Pradesh region and the Udanam area. But very few, if hardly any, reports on the kidney morphology as of yet. I found this one in Indian Journal of Nephrology. It is available online, but it's not been published yet, or it's not in print yet. And they present 5 cases for biopsy: blunt sediment, no diabetes, and hypertension. And they say that the biopsy evaluation showed chronic tubular interstitial nephritis. Okay. But if you look at this result, they also have a high percentage of glomerulosclerosis in many cases and a varying degree of inflammation. These are some pictures that I found, and here you can see a lot of inflammation in this slide. But here you also see the signs of thickening of Bowman's capsule. Okay, so now I will talk about this publication that came out in February of this year from Vervet and colleagues. And they have been looking at 34 cases with CKDu, or CNAC, as they call it, from Sri Lanka, El Salvador, India, and France. And they present this finding of silver positive granules in the proximal tubular cells of a varying degree. In some cases only locally, focally, and in some cases more bigger and more dispersed. And by electron microscopy, they describe these dysmorphic lysosomes containing large electron-dense aggregates. And this also is found in 81% of these CNAC cases. And they also looked at the controls, mostly different type of drug exposures, and also transplanted patients, and they found these dysmorphic lysosomes in many of the lithium patients, but also in many of the transplanted patients, and in some of the interstitial nephritis patients. In this study, they also present a rat study where they had 3 groups of rats that had been treating for 4 weeks, 1 control group, 1 with dehydrated rats, and 1 treated with cyclosporine. And they present that all groups had these silver positive granules seen by light microscopy, but that the amounts were, there were more of these granules in the cyclosporine treated group, but they don't present any specific data. They also presented a subset of these lysosomes in the cyclosporine treated group were dysmorphic in this picture here, but they didn't have these electron dense aggregates inside the lysosome as they have showed in the CNAC patients. So the authors proposed that the lysosomal lesions found in the CKDu is a tubulotoxic mechanism similar to calcineurin inhibitor toxicity. The authors also suggest a link between calcineurin inhibition and pesticides. So our group wanted to, well, because the silver positive granules in tubular cells are considered to be an unspecific finding, we went back to look at controls and other biopsies. And this resulted in a letter to the editor to Kidney International regarding the VERVET study. And this was actually available online just a couple of days ago. And in this letter to the editor, we write that we looked at 5 randomly selected controls, and this was healthy Swedish kidney donors. And we found these dysmorphic lysosomes using the diagnostic criteria stipulated by VERVET in his publication. And we found these dysmorphic lysosomes in all 5 of these controls. We also wrote that we also have observed silver positive granules and dysmorphic lysosomes in other kidney diseases such as FSGS, allergic interstitial nephritis, IgA nephropathy, and thin basement membrane disease. We also wanted to comment that we don't see any hallmark signs of calcineurin inhibitor toxicity in CKDu patients. That is normally the hallmark signs are isometric vacuolization and arteriolar hyalinosis, and that is not common in CKDu patients. Okay, so to summarize this up, Mesoamerican nephropathy has a unique combination of morphology findings in renal biopsies with chronic changes to both glomerular and tubular tissue compartments. Glomerulosclerosis can be extensive, and glomerular enlargement, hyperfiltration may mask the degree of chronic injury if you only look at the eGFR or creatinine. Electrolyte disturbances with low sodium, potassium, and magnesium is common and probably secondary to tubular damage or renal losses. Acute Mesoamerican nephropathy, an inflammatory febrile illness with acute interstitial nephritis, may in some cases precede the development of CKD. CKDu in Sri Lanka has many similarities with Mesoamerican nephropathy, but larger studies are needed to evaluate this better. Silver positive granules or dysmorphic lysosomes in proximal tubular cells are not specific for CKDu, but may be an important finding. And we need to further studies to look at this and also to semi-quantify these changes in both CKDu cohorts and controls. So what are our future challenges? Well, I think we need to improve the comparability of biopsies from different CKD regions. And last year in Costa Rica, our group was a member of the working group on renal pathology, and we together worked and made a joint template for biopsy evaluation. And we hope to have further meetings and collaborations in the future. I think it's important to look at more biopsies and biopsies from other regions, more in-depth analysis of tissue, and of course, more experimental studies. So I want to acknowledge all my co-workers around the globe in Sweden, El Salvador, Nicaragua, Sri Lanka, and India. And actually, we have conducted a biopsy study in India recently, and I hope that we will be able to share those results with Senkan and you in the near future. Thank you for your attention, and I hope that you have some questions.
Yes, thank you very much, Julia. So the talk is open for any question or any comment. You can use the Yeah.
Hi, how are you? This is Carmen Avila Casado. I would like to make a question, if possible.
Okay.
Well, a comment.
Introduce yourself and make your questions. Very welcome.
Yeah. So, hi, Annika. I enjoyed your presentation. Thank you very much. I just want to mention, I also had a series of patients from Honduras that we presented and at the USCAP a couple of years ago. And we got like 16, 17 biopsies, and our findings were very similar than your findings. And my question is, what do you blame for these vascular changes you see in all the biopsies? You see the vessels have thickened walls, and patients are not hypertensive, not diabetic, not other, and also we explore other features, for example, weight at birth, because thinking that this patient may have, a low weight at birth and they may have hyper compensation, glomerular nephron hypercompensation or something like this. But we explored this possibility and we couldn't find any explanation for these large glomeruli and these vascular changes. So I saw your presentation. I know the description is nice, but I would like to know more what you think about the vascular changes. Thank you.
Well, thank you. Well, we didn't see that much vascular changes, actually. The changes was mostly mild and in many cases normal vessels, but you see more vascular changes in your cohort, is that correct?
Yes, but you saw a glomerular hypoperfusion. You described periglomerular fibrosis and
the glomerular ischemia. Yeah.
Exactly. So this is an indirect finding of for hypoperfusion. So what do you think about it?
Well, it's a very good question, and I really well, of course I've been thinking about it, and I don't really know, but of course it could be that it some kind of ischemia has happened, and what has caused that ischemia, well, I don't think that we can see that just looking at the biopsies. That we have to know from the clinical picture and history of the patient, but it it's a difficult question.
I know. I know. I mean, there's probably no answer, but I would like your thoughts. I'm also working in that area. I told you in Honduras, so we are very interested in trying to find something, because we haven't. We describe, but there's nothing new to say why this is going on. That's the next step. As you mentioned, probably, of course, more biopsies, of course, animal studies to reproduce the features, and probably put it, something else to try to describe why is this happening. Thank you very much for your interest in it.
Thank you.
May I interject, Julia? This is Shuchi. So what do you think about some of the ischemic changes being related to extreme tubular damage and then secondary glomerular dropout?
Do you mean that the tubulointerstitial chronic changes or acute tubulointerstitial?
Either, if there is tubular cell death and significant tubular changes, then potentially you could see secondary glomerular ischemia. Yeah,
and what normally if you and I'm not a pathologist. Annika Wernersson is the pathologist, but when we have discussed this, and we all, she and our other pathologist, Magnus Söderberg, he also said that the degree of the percentage of glomerular sclerosis is too high to be explained only by the chronic tubulointerstitial changes. So normally when you have a tubulointerstitial disease, of course you can have secondary glomerular changes, but from the pathologists that I'm working with, they don't think that this really adds up. So something is affecting the glomerular. But I know that other groups working with these biopsies think it's a secondary glomerular damage. So
can I comment, Annika, here?
Thank you. Yes, that'd be great.
Yeah, I agree with what Julia said. We think that as Julia said, the balance between the degree of glomulosclerosis and the degree of tubulointerstitial change, it doesn't fit, so to say. So and also these, it should be, I mean, more tubulointerstitial changes if you compare it with the degree of glomulosclerosis, and also we saw actually very mild vascular changes. So we don't think vascular changes can explain the glomulosclerosis. So therefore, as Julia also said, I mean, we connected more to ischemia, but also there could be some other, of course, some other glomerular injury that we not know now, not yet at least. And the hypertrophy of the glomeruli, that I think is a secondary thing, secondary to loss of nephrons, because then you have hyperfiltration in the remaining glomeruli, and that could end up with segmental sclerosis. Yep. So that makes sense. But I mean, this was unexpected for us to find this. So, and we don't have any clearer explanation than this, but it's of course interesting. So we try to figure it out.
Yeah, for sure. And then Dan Brooks has asked a question that is a more general question, Julia. So if you're taking a look at this presentation from a non-physician perspective, what do you think, what is a sort of a global statement that you could make about what the studies show, what the biopsies indicate for potential etiology?
That was a very difficult question. This is a descriptive study, and of course has a limitation in evidence value. I think this is a piece of the puzzle, but we need more pieces to get the picture. So I think we should be. Maybe I can think what I what I maybe think, but. We can from this picture. I can say. I'm sorry.
Well, I mean, one thing we could say is that generally when we see kidney disease, it's more commonly affects the glomerulus, and it's more related to autoimmune phenomena or systemic things like diabetes, and we don't see that.
Yes, of course. That we can say.
Autoimmune phenomena, we don't see systemic evidence of a systemic disease process here. That's essentially what we can say.
Yes, and we can say that this looks like a specific disease. Mm-hmm. It has features of other disease, but a combination is somewhat unique for this disease.
Yeah.
So Gerardo Arroyo from Guatemala asked a question. Would you please comment on KDiGO stage of biopsy patients and pathfindings, trying to understand the timeline of developing the disease?
So one more time. The KDiGO guidelines.
Yeah, he wants to know the KDiGO stage of the biopsy patients that you show us.
Aha, okay. So they were EG for 30 to I think we maybe to 80. So that is stages 3 to 2 to 3, right? Am I correct?
3 to 4.
3 to 4.
Yeah.
Sorry.
Mm-hmm.
Sorry, we have a different, maybe I have a different system here in Sweden. Sorry.
All right. There are any other questions. Rodolfo Guzman asked, any comment on a low glomerular endowment as a risk factor for developing CKDu?
So the glomerulosclerosis being a risk factor for
endowment.
Sorry.
Any comment on a low glomerular endowment as a risk factor for developing CKDu?
So I hear you. I don't hear you so good. The low glomerular
endowment.
Sorry, I don't understand.
Maybe Rodolfo, can you amplify your question, or you can use the mic?
Maybe I think he's referring to like low nephron mass as a potential, like
Yes.
as
Yes.
a potential risk factor.
Yes. So as the first question, about low birth weight. Of course, if you are born with a low nephron number, of course, that would make you more susceptible to kidney injury and glomerular hypertrophy and so on. Of course, yes.
Ramon Garcia Trabanino asks, what value could the silver positive granules and dysmorphic lysosomes findings still have in the future if they are non-specific?
Well, in the Vervet study, in the Vervet study, they didn't really semi-quantify these findings. They said that it could be found only in one part of the kidney, or it could be widespread in the kidney. So I think that maybe it's more widespread in CKDu patients. I don't know, but that is something that you could look at, of course. Even if it's not specific, it could mean that it has some, could be a sign of tubular stress or injury or, yeah. So that, of course, could be interesting to look at. But I think that they take it a bit too far, connecting it with CNI, toxicity, and the pesticides. That I think that's too early to draw those conclusions.
I think Ramon is asking a similar question. In your opinion, is the glomerular damage primary or secondary to the interstitial lesion? And I think we just discussed that as well, Julia. And then a second question from Inike is, if histopathology seems to be typical for Mesoamerican nephropathy, would you say the same for Sri Lanka?
I think I need to see more biopsy studies from Sri Lanka with larger materials before I can say that. It wasn't like our first studies in Central America was kind of easy because all the biopsies had the same, we had the same kind of findings, but in Sri Lanka it wasn't that case, and we also had a small number of the patients, but it looks somewhat similar, of course. Yeah.
Bueno, yo podría, ¿puedo hacer un comentario? No
Sí,
se
claro.
oye.
Identifícate y lo haces.
Sí, Jorge Vargas, de Costa Rica. Es que, vamos a ver, creo que no tengo imagen. Sí, en mi hospital, el Hospital México de San José de Costa Rica, ¿verdad? Hemos tenido un número aproximado de 13 biopsias de
Voy a ir traduciendo después.
Okay, well,
partes, ¿no?
in our hospital, in Hospital Mexico in San Jose, Costa Rica, we have received nearly 13 biopsies, but in a very long period of time. Unfortunately, we have not been able to review this in recent days. However, the main finding was chronic interstitial nephritis with global sclerosis in very few cases. These biopsies, the remaining tissue block was taken by our nephrologist, Dr. Cerdas, to the Karolinska Institute several years ago for detection of toxins. But according to the information he gave to me, the toxin research was negative in the Karolinska. So this is just the main. We are trying to review these cases, but since they have been for so long time, to find these slides in our archives, it's very, very difficult. But we hope to do it sometime in the near future. Thank you so much.
Sounds interesting. I haven't heard about the slides. We haven't been involved in the slides on the analysis of toxins that I know of.
Mm-hmm.
But good luck.
Oh, thank
And
you.
it's very important. And I think it's very important that different groups also work with in this area. So we have different perspectives.
Here is a really interesting question from Rodolfo, and he asked, which would be the next challenges for research in CKDu?
I think it would be important to look at tissue in different ways, with new methods, looking for different substances or particles, or it could also be the acute phase. Look, it could be also, it could be maybe an infection. We don't know. So I think that we need to have an open mind and look at different ways. But I think that new techniques will be important to resolve this mystery.
There is one last question from Krishna Kumar. He wanted to learn more about Udnam nephropathy. Do you know if there's any information regarding its relationship with heavy metals, especially in that study that you showed us with images from India, Julia?
Yeah, I don't remember if they had been looking at. I don't think they have been looking at the heavy metals, but I know that there are some other publications. But I'm not really sure. Maybe I can get back to you with that.
I can tell you, Krishna Kumar, in Sri Lanka, they've looked at heavy metals quite a bit and have not found, at least in the water, sources of evidence of presence of heavy metals above EPA standards, but they have looked at, but they have implicated potentially fluoride has been one that they talk about a lot in their literature as a potential trace element that's present in high quantities in their water supply.
Well, I was given permission to ask a question. Julia, you were now talking almost exclusively about substances or particles or whatever, but our group recently just published a pathophysiology paper about heat stress, how it could damage the kidney. So yes. How to link that to biopsies? Because for example, the biopsies of the acute injuries, I think that those are very interesting, and we should, if we keep an open mind, we should really go into that direction, at least in Mesoamerica. I am not so convinced, but who am I, that in Sri Lanka we have the same disease or the same set of causal agents that is causing it. There must be something that links, but maybe not all. But if we just look at Mesoamerica, the evidence for heat damaging the kidney, the epidemiologic evidence, and also the physiopathology theory now is very strong. So how could we go about it?
Yes, I agree. And then you could look at the tissue, you could look at different types of gene expression to see if different pathways involved in heat stress or involved with the dehydration or inflammation. Maybe that would be a way to go to look at that hypothesis. And I agree that there is strong epidemiological evidence that heat stress or the working conditions of these sugarcane workers are important for development.
Okay, Julia,
may I comment?
Yes, please do it.
Yeah, it's Annika in Sweden working with Julia. I was just thinking about Inike's question. I mean, there are very seldom that we look at biopsies from acute kidney injury. I mean, not related to more like when patients have nephrotic syndrome and so on. So we don't know that much about acute kidney injury and the findings in renal biopsies. So of course it would be very interesting to look at the acute phase, and also, and that is a problem, as you know, Ineke, but that would be very interesting to see different stages of the disease and how it develops. And I think, as Julia said, if we can also add information by using other techniques, maybe we can, that would probably be very helpful. But we need more biopsies, and we need biopsies that are taken in a systematic way and analyzed with the same inclusion and exclusion criteria, so we exclude hypertension and so on. But we need more material, more biopsies, and we need to collaborate and be able to compare the biopsies from different regions.
Yeah, no, I agree completely. And collaboration is key, of course. We cannot do this on our own.
No.
We have to between the countries and also within the region, and people who think about different etiologies, because, well, open mind, but we have also to be guided by the evidence that is appearing. And right now in Mesoamerica, that is heat stress. Actually, there's no evidence for anything major, at least key etiologies. Others that can contribute, yes, sure, and also toxins, of course, but that is what there is at this moment, and the evidence is strong. So we should really think about how do we get into that.
Actually, there was a case report, I don't know if you have read it, about a long distance runner in China who had been running without drinking for several days every week, and he developed acute kidney disease and then injury, and then chronic kidney injury, with somewhat similar findings to what we have described. But it's just a case report, but it was.
There sports literature. There's a lot that we can look at, as did Eric Hansson in the physiopathology paper.
Yes.
Yeah.
I have a question, Julia. In the recent ASN, the group from Denver in Colorado showed some data about silica, and the involving in the pathophysiology of the kidney damage. You have any comment about the silica, some studies, or is just an observation?
I think it's important. It's also like these silver positive granules. It's very important to also, if you look at different compounds in kidneys, to also look at the control material. Is it also, can we find these elements in normal kidney tissue or in other kidney diseases? So I think that is really important when you look at that.
All right. Any other question, other comment? If not, Sochi, you can.
Yeah, before you close, Vicente, I just wanted to thank everyone for attending, and also wanted to advertise that although.
Sorry, can I make a really quick comment?
Sure.
Yeah, very brief. We just submitted a grant to NIH, a group of us, and I can tell you that the initial findings in silica are thus far interesting, but they certainly aren't present in all those with disease. So we submitted thus far and what we're looking at in the grant, and I believe Julia and Leva and a whole bunch of us are on that. So hopefully we get to answer it, because the signal seems to be
Jason, I think you're losing your connection. I hear you. Julia, you want to elaborate?
Oh, I can shoot an email. Don't worry about it.
Okay, sorry, it was just not coming in clearly. Julia, do you want to elaborate on potentially, or what he was mentioning?
Well, and I think that Rick Johnson presented at ASN that they have found some silica structures in CKDu patients, and he's received a grant to look at that in more detail. And we're going to be a part of looking at that with him.
Perfect. Thank you. So I just wanted to say that thank you everyone for attending today. And while we had planned for these webinars to be quarterly, there has been such great attendance and such great engagement that Marvin is putting in extra hard work and hopefully planning a follow-up one in July that will be oriented around intervention studies. And so we look forward to having all of you join and more people who are interested in joining around looking at what interventions are being planned and implemented in mostly field settings in Mesoamerican nephropathy. And Vicente, I'll let you close. Thank you.
Right, so thank you very much for attending this webinar, and next month probably we'll have the other one. So please join us at SEMCAM. We are a group that want to many other people participate involved in our programs, in our website. So thanks for attending this webinar, and particularly Julia, thank you very much for your interest in participate, and also the really nice talk. We understand as clinicians that we must perform more biopsies and give you the opportunity to participate with us in this really important meeting. So thank you very much. Good evening, good night, and be safe, please, at home in your countries. So bye-bye.
Okay. Bye.